Okay, now we'll be discussing about the graft versus host disease. Okay, so graft versus host disease, the mechanism here wherein the grafted tissues or organ containing your immunocompetent T lymphocyte try to destroy your host tissues. Okay, so it's not the other way around. It's not the host that try to destroy here your grafted na tissues, but it's the grafted tissues which try to destroy here the host tissues. Kaya nga graft versus host and not host versus graft. Okay, so why does or how does this graft versus host disease here try to occur? So number one, the patient requires there's a need for the patient here to undergo transplantation because maybe because the patient is immunodeficient or maybe because the patient here would have some like problem in the bone marrow where the patient require here to be given a unit of the blood, an organ, or a tissues. So your organ, your tissues, or blood or stem cell here become the source of your immunocompetent T lymphocytes. Okay, then the second factor here will be the difference between the HLA of the donor recipients. So it should be compatible with one another. But in the case wherein they are incompatible with their HLA, so it will have your higher chance of your graft versus host disease. And lastly, once you try to transfuse the unit of the blood containing the immunocompetent T lymphocyte, normally dapat once that immunocompetent T lymphocyte is being given to the host we're going to recognize this one as a foreign antigen. And therefore, the host, we're going to kill that one. What happens here, the graft versus host disease, is that once the tissues organ has been introduced to the host here will not able to recognize this one as a foreign antigen. It's because here the host is immunodeficient or immunocompromised, and therefore it will not mount a harmful immune response, but we just let the immunocompetent T lymphocytes proliferate in the body of the host. So once this immunocompetent T lymphocyte try to proliferate, they try to have here, eventually try to produce here much of the cytokines which are cytotoxic, and eventually try to infiltrate, and eventually result here to the destruction of the host tissues. And again, in the graft versus host disease, it's the grafted tissues containing your immunocompetent T lymphocyte, the one we're going to destroy the host tissues. Okay, classification of your graft versus host disease could have here the acute and the chronic. Acute occurring here less than 100 days after the transplantation or the blood transfusion. And this grafted tissues containing immunocompetent T lymphocyte try to target here for the destruction, the skin, the gastrointestinal tract, and even the liver of the patient or the host. Okay, so nagkakaroon siya ng destruction here because number one, if there is a mismatch between the donor recipient, so your transplanted tissues containing the immunocompetent T lymphocyte, if there are mismatch, will be going to target here the mismatch na HLA with your HLA antigen in your recipient. But if they are matched, then your grafted tissue here containing the immunocompetent T lymphocytes try to target the minor HLA, and then eventually try to result here to destruction of that. For the chronic graft versus host disease, again, is one try to occur here for more than 100 days and try to target here the skin, the eyes, your mouth, and some mucosal surface. So same mechanism, only that it would have here occurring only at a longer duration of time compared to your acute graft versus host disease. Okay, then we have here the HLA typing. So again, when we're having the transplantation, make sure that the donor recipient should be compatible with one another with their HLA. So we could have determined here the HLA type between the donor recipient could either be genotyping or could also have here the phenotyping. Phenotyping, so it might be just like our blood typing. Okay, so example of your HLA phenotyping, we have the CD0 complement dependent mediated cytotoxicity. So you are detecting here for the HLA antigen in your recipient or donor. That's become here your sample of your patient. So for the MSC class 1, so ang source ng sample natin is purified T lymphocyte. For the MSC class 2, your purified B lymphocyte will be the source of that. It should be alive na cells. Okay, then since you're detecting for the HLA here in the form of your antigen, so ang reagent natin should be in the form of antibody. So it should be a monoclonal HLA panel of antibodies because we wanted to know here the different types of the HLA antigen on the patient sample. Then after that one, you try to add here the complement. So basic formula or basic principle here that if you have your HLA antigen, you have your antibody, anti-HLA, so able to form here immune complex. Then pag nag-add tayo ng complement, it would result here to the cell lysis. So if your reaction here would result to cell lysis, meaning to say that patient contains a specific HLA antigen with your corresponding HLA antibodies or agent. Then you need to add here dye in order for you to visualize their action. So dead cells, we're going to take up the dye, and then it will be colored, and your alive cells here, mean to say, pag alive ang cells, mean to say wala siyang corresponding HLA antibody, so it is not, wala siyang HLA antigen. Okay, then that's what you're going to observe here for the percentage of your dead versus your alive cells. Okay, the next one, we have here the solid organ transplantation. So we're going to have here transplantation with different solid organs. So we have here the different solid organs and their relative immunogenicity. So from here down there, so this is the most immunogenic. So bone marrow is the most immunogenic, followed here by the skin transplantation, followed here by islets with longer hands. We have your heart, kidney, liver, bones, and we have your xenogenic heart valve. And finally, we have the cornea. Cornea is the least immunogenic of them all because this one would have here a vascular, wala siyang blood compared with the others. Okay, so again, we're doing the solid organ transplantation as a replacement for your organ damage, mga end-stage organ damage. So you don't have any option but to have transplanted it from a donor because again, it's no longer able to be responsive with the treatment. First one, we have here the bone transplantation. So we're doing here the bone transplantation primarily for the replacement of your bones, which would have your congenital bone abnormalities. Sample for that is also for the treatment of your limb-sparing tumor resection. Okay, so we have here the requirements for the donor of your bones. Again, your bone here could be transplanted either as allograft or from same recipient and a donor, or could also be allograft, you have here the other donor from your outside your body, and could also be an autograft or from one patient or one part of the bones of the patient transplanted to another part. Okay, we have here the requirement for the donor. The donor should have here no malignancy, should not be under IV drug use, or even history of your human growth hormone replacement therapy. Okay, so when you're harvesting the bone here, it should be in a frozen state, and then should include here the periosteal sheath because it's the one is capable of, because the periosteal sheath is actually the one trying to contain here the osteoclast or bone cells. It's possible here for growing and reproducing here, regenerating your new bones. Okay, so immunosuppressive therapy here most likely not being um, given here to the patients because their bone here is not very immunogenic. The next one, we have here the corneal transplantation. Corneal transplantation is for the treatment of your non-healing corneal ulcers. Okay, so this will have here the least immunogenic of all our solid organs. So minimal graft rejection because number one, wala siyang blood, a vascular. And second one, we have here decreased concentration of the expression of your MSC class 1. And the second one, we have here the absence of your MSC class 2. And therefore, less immunogenic because wala siya masyadong antigens. Okay, so requirement for the corneal transplantation. So the smaller, the better here. And at the same time, we put it on the center of the eyes of the patient and prevent that one to be in contact with the limbic system para hindi siya mag-contact ng ating vascular system. Okay, another one, the patient is not receiving immunosuppressive drugs because again, this one is less immunogenic. Okay, the next one, we have here the heart transplantation. So the requirement for the heart transplantation would be the same as our renal cadaveric transplantation. Okay, so the requirement for that, the donor should eventually be having this irreversible brain death but near normal cardiac function. So to say the patient is about to die but still have his normal cardiac functions. Requirement for that, so the patient, the donor should have no malignancy. Then the donor, the donor of that. Okay, then we have here the donor should eventually also receive the following, should be given cytotoxic drugs, or even we have also here your prophylactic drugs. In part of the recipient should receive also here immunosuppressive drugs. That's to lessen here the immunogenicity of transplanted tissue to prevent the rejection process. The recipient also should try to receive here anticoagulant, antithrombotic drugs, and less or decrease lipid concentration diets. Okay, to monitor here the patients with the rejection process, you could have your myocardial biopsy. You could also have here the quantitative determination of the mononuclear cell gene expression in the blood of the patient. Okay, next we have here the heart valve transplantation. So this is xenogenic, meaning to say this could be from here the animal as your source or the donor of your heart valve. So basically, although we have here four heart valves, the tricuspid, we have also your pulmonary, we have also here your aortic and mitral. So most likely what's being transplanted here would be the mitral valve, could also be aortic valve. The source of your heart valve could be in the pig. Okay, that's your porcine. Could also be the bovine here from the cow. Okay, then before it's been transplanted, your heart valve should eventually undergone here processing. It should be it should be physically and chemically processed in order for that to render that one less immunogenic. Okay, next one we have here the intestine transplantation. So this is basically for your patient with a short gut syndrome. Okay, so intestine transplantation could most likely be only intestine or might be along with the other gastrointestinal tract organs. So if the transplanted tissue here is only the intestine, you call this one as isolated intestine transplantation. Okay, for the requirement, the donor should have your stable cardiac function, cardiopulmonary function, and will also should have a normal liver function. For before the patient is being given here with your intestine transplantation, the patient should receive here the contamination process by nasogastric suctioning with the use of your polyethylene glycol. For the next one, we have here the kidney transplantation. So this is basically for the treatment of your end-stage renal disease caused, example of with your caused here by your diabetic nephropathy. Okay, so recipient, we have exclusion, old age, malignancy, sepsis, DM, hypertension, so most likely they are not given with this. For our donor, so nagiging prevalent donor here would be 55 years old or above, or even with those having hypertension or DM are being accepted as a donor. The best donor here would be cadaveric, mga those patients having this young trauma victim na mga patients, provided here that the organ has been removed easily as soon as the patient die. For the survival of the graft here, so we have here the very important considerations. So it should be matched between the donor recipients. So number one, we have HLA A and B, your MC class, so HLA-DR. Should also compatible with the Lewis antigen, and we have also here the HY antigen. Okay, the next one, we have here the liver transplantation. So when you are transplanting for the liver, not the entire liver is being given to the recipient, but rather only part of that or just a hepatocytes. Just let it grow. Okay, so this is for the treatment of your congenital biliary atresia or even for the patients having the liver cirrhosis. Okay, for the survival here is highly dependent on the HLA type between the donor recipient should be matched. Another one, because it could also be because of the immunosuppressive drugs which be given here to the recipient that would try to slow down here the rejection process. So we have here azathioprine, we have also here corticosteroid, and we have also here your cyclosporin A. Okay, for the complication, you could have here your biliary tract fistula or leak. And then we have here the lung transplantation. So major consideration for the lung transplantation such that the donor recipient should have the same bronchial circumference para fit siya. Okay, so most likely lung transplantation, we have here a lower success rate because of the following. Number one, it's very sensitive to ischemic attack or damage. Second one, we have here the difficulty here in the preservation of your lungs after harvesting. And another one, we have here susceptible to the sepsis because of this one. So high level of your high density 1A, positive cells in your vasculature plus high level of your WBC trap in the alveoli of the lungs, making that one highly prone here to your infection or sepsis. Okay, the next one, we have here the pancreas transplantation. So this is for the treatment of patients having the diabetes. Okay, so when you're transplanting here for the pancreas, it could either be the whole pancreas, it's only part of your islets of Langerhans. Okay, the success rate is very low, and at the same time is very short duration lang. And this become more successful here if you are transplanting only small quantities of the islets of the Langerhans rather than here the entire islets of the Langerhans. We have your types of plant transplantation with your pancreas. Could be a pancreas kidney. So majority of transplantation would be pancreas plus a kidney at the same time. You could also have your pancreas transplantation after your kidney transplantation. That's 18% of the transplantation rate. And we've also here pancreas alone, the transplantation occupying only 9% of the transplantation. And lastly, we have here the skin transplantation. So we have here a lower rate of the successful transplantation, high rejection rate because of on your skin is highly immunogenic because this one is trying to express here high concentration of your MSC class 1. And the success must be attributed also here with the administration of the immunosuppressive drug to down regulate the immune system of the host in order to prevent that one from its cytotoxic activity against the grafted tissues to prevent the transplantation rejection. Okay, so that's the end with this topic. Okay, thank you very much.